We work a lot. Okay, all of us, we really do hard work. If you ask myself, I think we would have, just one example I would like to give you. Trauma belongs to my specialty, bread and butter of our specialty. We would have treated some more than a few hundred cases of trauma. But if you ask me today, show me at least 10 trauma patients with the complete photographs. I don't have. We always have mobile with us, which is highly predictable and reliable. We don't believe our mobile. We feel always that we cannot take professional photography in the mobile. We always feel that. But when Dr. Anil showed me a few months back some photograph, and I asked, when I look at the photograph, I felt it must be some great camera. But then he mentioned, no, it is by one of my close friend, Dr. Akash, who uses his mobile, and I was shocked to see that. Mobile photography with all saved, beautifully saved and labeled, and I couldn't believe that. So that way we thought we'll have a program on this.
Today, Dr. Datta brings to you his 20 years of clinical expertise and knowledge in field of dental implant surgery, implant restoration and cosmetic dentistry to provide long-lasting results. As a speaker, he has devoted his time to teach advanced concepts in dental implant treatments to fellow dentists internationally and nationally.
On this auspicious day of Akshaya Tritiya, I welcome all the delegates and dignitaries for this wonderful CDE. Practice management, we all need it. And Dr. Datta has come all the way from USA to teach us some success mantras for us. I welcome you, sir. Our second speaker, Dr. Akash, is a master photographer, besides being a successful periodontist and implantologist. So we all will learn how to take good clinical photography with smartphones, apart from taking good selfies. I welcome you, sir.
Okay, unless you want me again. Got it? It's been 22 years in clinical practice. So 2003 was the time that I decided it was time to start my own. Since then, we have grown into 2 locations in the US, and something happened in 2009 that I wanted to do something back here. So that journey inspired me and transferred to opening up 2 more locations in Bangalore to see that if I can change a perception of clinical practice. So you can't just open a practice, you have to build it. Today, I was presented with a plant. It has a responsibility. You have to nourish it. How different is the management? It's no different. You have to take care of it every single day. You have to be there. You have to check it. Then it can grow into a tree. It's my small group of team, what you're seeing here. So they are all mostly specialists working with me here. We decided that we build in all the departments, very much clinical departments, periodontics, orthodontics, prosthodontics, and restorative and endodontics together under one roof, so that we can have a cross-culture communication to provide a complete treatment. That was the goal what we had. If you're not smiling, you're not inspiring. You have to smile. Rule number 1, you have to smile. You should have some humor. Oral surgery department is already lucky to have Dr. Anil there. Okay? He's going to crack all the jokes, right? So you better laugh at it. I shared this simply for one reason. It's not because of what we're doing. What is that you have potential to do? This is what I want to develop. That's why I have more practices, because I see we don't have enough clinical practice with good organized dentistry or standards of care to meet what we have back in US. Please don't take me wrong. I practiced in here in Bangalore, and I practiced there. I still practice here when I come here. I just don't come and sit. I have 6 days of clinical schedule next week. Sorry, I'll take that back. 4 days of clinical schedule, 2 days of management. So these are some of the topics I would like to share. Some simple rules for all of you today. Clinical practice, 28 minutes before, 30 minutes before. When I started my practice, I used to go 1 hour before. Just 2-man team, 3-man team. You had to set up everything. You had to run the show all day. Do you have a plan for your day? Second word for the day. Go to dictionary, define plan. Please note, the definition of plan is different than what you think. Please read it again. How many of you think plan means something is going to happen? Something to create future. I'm still working on it. I'm working on it for the last 20 years. Why do you need to manage? By the way, that's my son. It's called zip lining. So, why do we need to manage? To know your journey is very important. You have to manage the journey of your practice because it's going to change every year for you. Key takeaway for today in management. Start with yourself. I want you to reflect and see how punctual you are, how much written plan you have for the day. What is that you would like to achieve for the day, for the week, for the month. If there is something you have to give away, you have to manage yourself first. Write a written set of goals and work towards them every day. So every one of you, if you're going to take up a paper and pencil, if you have your phones, please make a plan for next 3 years, today. I don't care if the plan is just one. Can you make a plan for yourself? I can give you some more analogies today to learn. How long it took for him to become a cricketer? How many of you know this? Age 4. By 14 he was playing in Ranji because he was already at that level for 10 years. He had already put his time before he got selected. By 16 he was in the Indian team for 15 and a half. You develop a team. You need a captain. That's going to be you always if you have a practice. Who do you blame if your team is not performing? Captain. Just go back when the team fails. Do you blame whom? Captain. If the captain cannot decide who is going to bowl, what happens? It's going to be a challenge. That's my team. Do you see them happy? It's a requirement in my practice. They have to be happy. You can't come to my office without being happy. Leave the things behind the door. All your family matters outside the door. You need counseling, we'll have a separate time for that. No drama inside the office. That's your work ethics. Can you build that? We enjoy a lot. We take time for the team. Your practice is going to be better if you take care of your team. I'll tell you right now. How are you going to make a measurement or a plan saying that how you're going to pay it back with a profit? Okay, you invest, let's say 1 crore money in a bank today can yield 10% per year, right? How many are happy to say that I'm going to invest 1 crore and sit and play with that money? Well, let me share with you. Dentistry has a purpose, but your returns could be more if you're happy. These are goal setting for our practice. Revenue goals, profit goals, learning goals. Measure them by written goals. Why do you think you have quarterly exams? You are measured. Every practice should be growing at 20% per year. If you're not measuring from this year to next year, that means that you're not paying attention towards it. Good? This is something else you need to know. In a clinical practice, what we do is we set a goals for 3 years, 5 years, depending on your vision, how far you can see. You can't do it, hire a coach and mentor. You may know certain things in management, you may not know everything in management. So you hire a coach on that. There are many ways to do that. One, you can learn on your own. That's going to take some time. You're going to fall, you're going to correct yourself, but you shouldn't stop it. I believe in that. That's my family, that's my wife and son. We have a purpose. If you don't have a desire, you don't dream. It's okay to dream. Okay to have a desire. There's nothing wrong with it. As long as you know you're going to be truthful and honest towards your desires. So we started Study Staff Academy in 2013. It's very private right now. It's not for everyone. So it's based on invitation and what we put out because it's still baking the product. Academy was not ready completely until we know that it's ready to go. Thank you. My happy team. People are talking about how come you have only ladies here. They do the job right. They get it done. Okay. They get the job done right. That's the key. All right. They can be in my team only if they get the job done right. My practice has shifted over the time. One journey I undertook for years was mostly to run the best clinical dentistry. Every time I used to read a book in the library, guess what? Who wrote those books? It was written by US doctors. That's how I got inspired. And if there is something I have to learn the best, I decided I have to go and learn from there. That was one of my journeys. When I started with my journey there, I was focused only on full mouth rehabs. So ignorance was a bliss, if you consider, but I tried to explore something I was not ready to stop. Okay, here is a problem. If I start something, I don't like to stop. Whatever it takes to get through that. That could be a problem. Two, because you had to sacrifice a lot of time. So I was happy and blessed to have a family to support that. Okay. It goes with a relentless time of education, day and night. Because you come back from the school, it doesn't stop. You still continue to study. It may go up to 2 o'clock, 3 o'clock. You had to get it done. I started out with the restorative dentist and cosmetic dentistry, but there was element of implant dentistry that wouldn't stop me. Because at that time, once you become a cosmetic dentist, you want your treatments to be accurate and perfect. When my periodontist started sending me more cases where in the anterior zone, which I could not restore because they were offset, that's when I jumped myself into implant dentistry. It was in 2002. My journey was so simple, how I got into it. I had an old patient who came in there, I was an associate doctor. He was 72. I looked at him and told him, the front tooth needs to go, you need to put an implant in that. My senior doctor will do it. I want you to get that done. He looked at me and said, you can't do this. I said, no, I need to train, then I can do it. How long it'll take for you to train? He said, I'm in training, about to start my training next week. Maybe next month I can do this for you. Go and train, I'll wait for you. So that happened, I trained, I came back after a month, and I placed the implant. Okay. This patient could have gone to my senior doctor, but that was not his intention. Because I didn't know much, he didn't reveal a lot of his medical history, in spite of we have a strict standard of revealing the medical history. He wanted to keep it quiet. He knew that he only had a year and a half time left because of pancreatic tumor. But he did not want to make his life miserable thinking about it. So he kept his life very happy by helping people. So he inspired me a lot to say that, okay, I'm giving you something to do. All right? So today what I'm presenting you is just one small element of the implant practice I'm doing. This topic is a 2.5-day subject for me to teach you, but I'm going to concise that in 45 minutes. Okay? So there's a lot of things that's going to fly out. Stay open, be awake. If you have questions, just ask, because I'm going to go very fast here. Most of my time goes into regenerative surgery today. Grafting, developing tissues. That's where most of my time goes. On average, I would say today around 250, 300 implants is my time in a year. But the rest of the things goes to restorative. I lost a lot of failures too. It's the 5% failure is what currently I'm looking into my practice. I'm trying to improve that from 5 to 3 if I can. But that's the crux of restoring implants or doing implant surgeries. You need to see some failures. Okay? So I'm going to share with you why the failures are. And majority of the failures are going to be when you start exploring tougher cases, tougher bone conditions. You have soft bones. You have unmanageable patients. Those are the reasons for failure too. But in a clinical practice, but you learn a lot from failures. I want you to know, if you're not failed, you're not done enough dentistry. Okay? You need to learn from that. So this is my topic for today, implants and aesthetic zone, analysis of CDCT applied anatomy, risk factors in the aesthetic zone. I'm going to answer any questions you have. This is what I do day to day, so I can just share with you. This is where I used to learn from failures. This used to bother me a lot. This is from a long time. Why is the tissues, looking at this case, why did we lose the tissue? Especially the lateral incisor with the implants. We lost the tissue there, aesthetic zone in spine. Patient has a low lip line, so she would not show that, but to me it bothers, right? What can we do different? How about the case on the right side? You start looking at it and say that, what happened to the margins of the crown there? Why is it inflamed? Why is that we are depending on so much of an outcome where it becomes really challenging for us to say that it's aesthetically pleasing? How about these ones? This is not acceptable sometimes. What happened there? Did we have a poor data, poor lab technician, or poor clinician? Probably these are a combination. By the way, they are all my own cases. They're not edited. They're straightforward. Only cropping is done. That's all we do. How about the case on the right side? Why is that we have thin tissues on the implants? Done a long time ago, 12 years, 14 years ago. Why is the data so much different? What can we learn from this? How many of you are a periodontists here? Perfect. You are in my department today. Okay. Oral surgery? Yes, you guys are above us. I get to learn from you. But I'll share with you more about different things. There are two elements of implants. One is research articles and journals. I want you to read that more. I'm not going to waste your time on that. But I'm going to share with you what is applied knowledge and restorative principles. So you need to have an excellent anterior aesthetic outcome. Okay? There's one article which I'm going to take today and just break it down and show it to you why you need to have an applied knowledge of any particular articles you're going to read. Oral surgeons and periodontists, you have to pay attention to the articles you read. It's not just about reading, taking it and applying to your daily practices. Very important. It's mandatory for me. In the last 3 years, I have CDCT machine in my practice in both the locations in US, so that it becomes absolutely necessary. No implant surgery is done without CDCT anymore. It's not a requirement as a standard of care, but standard of outcome for me in our practice, it's a requirement because we don't want to fail. All right? So I want to open your eyes a little bit in terms about risks that exist by approaching anterior implant cases. I want you to know that it's not straightforward anymore, because in the last 2014 beginning we have the CBCT scan. So this is getting close to like 3.5 years. Approximately we have done close to like 1,500 CBCT scans, and analyzing each of the mouth, we get an idea that things are different. Every patients are different. Their bone density, bone volumes, and the angulation of the jaws. We're studying these things now. When I study these things, it becomes much more accurate for us to say that this is the treatment plan we'd like to develop for this particular patient. Why is this aesthetic failure? Due to poor early research data, poor understanding of anatomy and angulations happen here. We'll go into that detail. This patient was, she's NC, and she had this dental implants done by oral surgeon 8 years ago. It was good for 1 year. There was no tissues or no margins eroded. But after 1 year, she said that the gum started receding. She's an avid smoker. Probably they thought that may be the reason. Surgeon cleaned and said, don't do anything, keep it clean. Since there's no pain, no discomfort, we can keep it like that. And she believed that she is doing great too. Even today, she's doing fantastic. Most of the other doctors said that you should take it out and replace it. But she did not have any problem, and she came to me. She came for a different tooth. She came for different tooth implants because the surgeon retired. So we had an opportunity to say that, okay, let's go and take a look at the CT scan and see what we can see from this anterior teeth. We have very minimal amount of apical bone on the facial side, and almost on the palatal side you have 70% of the bone remaining. When we see this kind of image, what is that we could have done different in 8 years ago? Alright, so we can learn from that. So, are we going to remove this case? Are we going to keep this case? If it is functional, she is able to bite and chew, should we remove it? Now the question here is, you're going to fall into you're on the both sides of the swords here. If you say no, keep it, and when time comes to replace it, are you going to have enough bone? Right, so tissue is going to be an issue. Now, can you generate a bone vertically in the anterior region comfortably? That's the most challenging part. I want you to know that. It's doable, but you need to get your skills there. Okay? Many times it's easy to develop 2 to 3 millimeters of the bone, but 6 to 8 millimeters is going to be a challenge, right? Let's look at this one. A patient came, she is very much in the marketing and sales for her company. She went to the oral surgeon because her general dentist referred her to get an implant done. When she went there, she was given a flipper, and at the same time, she did not want a flipper. She did not, because she was not comfortable speaking with her marketing sales meetings. Every time flipper would move, she was not happy about it. So she lost confidence in a general dentist, and she started searching for cosmetic anyone who can help her. So this was the first step we looked into and say, okay, I'll take your case, let me take a scan and see what has happened there. Now, when you look at this, definitely we have a loss of buccal plate there. Now in the scan, I can see that thinning of the bone right in the front of the facial of the implant. How about this one here? Okay. What about the stability, primary stability of this implant? It's been 4 months now. Okay. That's what it looked like. So I told the patients, we have 2 choices. I'll go inside and see if it is primarily stable, then we'll regenerate everything what you lost. If the implant is not stable, we'll take it out and rebuild this. Okay. Now, what is that we learn from the CT scan here? Definitely, we have loss of bone. If it is stable, can we add the bone now? Yes. If you're going to add the bone, can we add the soft tissue grafting? Yes, we'll need soft tissue grafting. So these are the ways we start thinking about these cases now to see that if we can salvage or we go back and redo it. That's what happened. Post 6 months treatment, when I opened up the soft tissue area, surgical side, the implants were stable, so I had to graft it. First we developed a graft, and then also at the same time there was a 2 times grafting here. First time soft tissue and the hard tissue together, and the second time we came back and added 1 more soft tissue to be comfortable. All right? And that's the final outcome of the case. So once again, we start looking at the cases, and when patient comes to us from 10, 15 years ago, they had the implant surgeries and restoration. What is that led to this fail today? In the retrospective, we start to analyze these things. What is that they have done that we could avoid today, right? Loss of implant, soft tissue recession, angulation, and prosthetic issue were the main things. Looked into the CBCT scan, this is what we saw. So probably 12 years ago, they never had CBCT scans, and with the assumption they were able to do the implant surgery in this position though. In spite, we know that we have plenty of abundant palatal bone available, right? Now, these are calcitech implants. I don't know how many of you are familiar. When I started my journey in 2000 very much, I was introduced to most earliest implant systems. Calcitech and Spline are the original systems there. Today, very much you know them by Zimmer, okay? It's transferred into 3 different companies, and finally it stayed with Zimmer at this point. And how about the 2-dimensional images? With the limited x-rays, sometimes you may say that even with the angulation that you may not have enough length there. Look at that. Initially we thought that she doesn't have enough bone available, but post CBCT, she had bone. So with the 2-dimensional data, you're going to miss a lot of information though. With the 3D, we can definitely plan complete and more accurate implant surgery outcome, especially in the anterior zone. Let's take a look at this case here. The case of lateral surgery, lateral incisor with apical surgery done twice for this patient, and there was a bone loss and discharge. By the way, I don't believe in apical surgery anymore. Sorry, endodontist, if you are here still, because they're set to fail for after 5-7 years. We had to retreat with the periodontist extraction and implant. So this was apical surgery, and look at the bone loss there. And do you think we can place the implant and graft at the same time? Yes, very much a possibility here. And because if we get a primary stability, we see the lesion is somewhere in the middle, so we can do it. Immediate implants and immediate temporization. Okay. That's what the main criteria for today is, that you're going to see a lot of immediate restoration, when to do, when not to do. Okay. Guess what happened after 3 months? We tried to load the case and it failed. What did we miss? What happened? In spite we had 70 Newton's torque, what is that we missed in this case? I'll share with you some of the risk factors today in the anterior zone.